Well, a good cold afternoon to everyone. My name is Jessica Zavala, and I want to officially thank you for joining us for the Ohio Program for Campus Safety and Mental Health January webinar, CAMS, or Collaborative Assessment and Management of Suicidality. I also have with me Dr. Russell Speak. Russell, if you want to introduce yourself.
Hi, everybody. I'm Russell. Yeah, we really appreciate you braving, I guess, for potentially having a day off, or potentially not, but we appreciate you joining us. And I think Jessica's going to speak to this too, but we did a survey with you all pretty recently about sort of ways that you would like for us to better meet your needs through this webinar. And we have definitely taken that into consideration, and you will see that. And we have some upcoming topics, not only this one, but some others going forward that really, I think, dovetail with some of the preferences y'all had. So thank you for taking the time to do that survey, and we would like to continue to hear from you.
All right. So in regards to our webinar today, once again, we will discuss CAMS, or actually Amber Miracle will actually present on CAMS, who you'll also see here. CAMS is a therapeutic framework for suicide-specific assessment and treatment of patients' suicidal risk. It is a flexible approach that can be used across theoretical orientations and disciplines for a wide range of suicidal patients across treatment settings and modalities. CAMS, of course, was developed by Dr. David Jobs, and it is an evidence-based clinical intervention that has significantly evolved over 30 years of clinical research. Welcome you if this is your first time joining us. A few quick announcements before I introduce our presenter. Registration is open for the February webinar, Creating a Collegiate Recovery Community on Campus, which will be held on February 13th at 12 noon. Also, the PowerPoint slides to this presentation will be forwarded afterwards. Any other announcements, Russell?
No, I don't think so. I think that's it. Thank you.
All right. So, Amber Miracle is a licensed clinical social worker who currently works for the Department of the Army at Fort Leonard Wood, Missouri. She provides individual counseling to active duty Army, Navy, Marines, and Air Force station members there, along with their families, military retirees, and trainees. For the past 9 years, Amber has worked exclusively with the active duty and veteran population, with much of her focus spent on suicide prevention. Amber was a therapist participant in one of the randomized clinical trials of CAMS while she was stationed at Fort Stewart, Georgia, and from there went on to be a CAMS trainer. She has been presenting on CAMS and suicide prevention for over 6 years to a variety of audiences, including the Department of Defense, the VA, community mental health agencies, legal systems, and the general public. So without further ado, Amber Miracle.
Hi, everyone. Thank you so much for joining me and us today. I'm really excited for the opportunity to share CAMS with you. And I'm going to get my presentation pulled up. I hope everyone is staying warm, because I know talking with friends, it is something that is really frigid right now in Ohio. Here in Missouri is not as bad, but still pretty chilly. So just want to take the opportunity today to talk a little bit about CAMS, as hopefully you're cozied up with a good cup of coffee or hot tea. So let's get started. So here's the objective and outline for today. Hopefully by the end of this webinar, we'll have a better understanding of what CAMS is, and possibly consider if you want to pursue future training opportunities with CAMS. And here's my disclaimer. This is not the official CAMS training. This does not replace that. However, it's an opportunity for you to learn a little bit more about what CAMS is, and inform your opinion if you want to pursue the full and complete training, which I'll share with you at the end. There's a couple of exciting updates regarding training opportunities as well. A second disclaimer that is not listed here, since I am at an Army base, there are some interesting things that happen from time to time at Army bases. we're a training post for engineers, and if anyone knows much about Army engineers, you know that they like to blow things up. And today just happens to be one of those days that they are blowing things up. So I apologize if you hear any loud booms or bangs in the background. Over the last 30 minutes or so, they've been pretty minor, and I don't think they've been coming across. But just wanted to prepare folks that if you hear something, we're all okay. It's just the engineers having some fun. So I wanted just to take a minute before we really talk specifically about CAMS to be able to just review some of the statistical information related to suicide. So as clinicians, you know, mental health professionals, many of us know much about these numbers, know much about, you know, the epidemic of suicide, but it's an important reminder. And if you don't know these statistics, you know, sometimes that really kind of informs our practices a little bit differently when we realize the scope of the problem. And, you know, I just wanted to demonstrate or reinforce how great and significant the need is. I mean, these are our patients, these are our clients, the folks that we're treating day in and day out, and the need is significant. And specifically in this population, you know, we're dealing with a lot of people in a great deal of pain, very vulnerable, one of the greatest times of need in their life. So it's important for us to be mindful of that. So the first chart there on the left, it's a comparison between suicide and homicide rates. When I'm doing a general talk about suicide prevention to the community, this is very often one of my starting places, because many people are not aware that suicide outranks homicide in cause of death in the US. And the focus is so much more diminished on suicide compared to homicide. So just kind of starting with that general information. And then the slide on the right is, of course, a breakdown of demographically by age group, the trends there. And of course, we can see for the most part, it's an escalation, you know, over the course of the years 2000 to 2016. So again, on the left, this chart demonstrates among adults suicide behavior. So starting there at the bottom of the pyramid, annually there's over 1 million suicide attempts by adults in the US. And then 375,000, a little greater than that, results in emergency department visits. We have about 111,000 hospitalizations for suicide ideations, attempts, preparatory behavior annually, and a little over 41,000 deaths occur annually by suicide. And then the chart on the right, it just kind of breaks down some of that a little bit more. The greater circle, the gray, 10.6 million adults having serious thoughts. And out of those, we're looking at 3.2 who've made plans, 3.2 million, and 1.2 million made plans and attempted, and 0.2 had no plans and intent. So it was really that impulsive action that occurred for those folks. So this is just, you know, again, a demonstration of the significant need. So here's kind of where CAMS has come in. So CAMS was developed by Dr. David Jobs, and that's a picture of him there, as well as a picture of the most recent copy of the CAMS textbook. And you know, over 30 years of research has kind of gotten us to this point in informing what CAMS really is all about. He knew that there was a really significant need. And as Jessica mentioned, I began working with him when I was stationed at Fort Stewart, and I was a therapist participant in the randomized clinical trial. And I feel very fortunate to have had that experience, because it's greatly informed my practice when it comes to working with suicidal individuals And you know, it just allows for, in my opinion, a better, easier way to work with folks who are at risk for suicide. All right, so this is taking a look a little bit about current practices that are not CAMS. So it's really structured where the patient is looking to us to be the expert, right? So they come to us with many significant, you know, needs and concerns, and you know, they lay it all out there. They expect us to kind of fix it. The burden is on us in that regard, because they're in so much pain that they want this to be fixed yesterday. And so, you know, we begin the assessment process, and when we're assessing, we've generally looked at suicide as a symptom of a greater problem. So suicide is a symptom of the person's depression or borderline personality disorder, let's say. And so when we have looked at our treatment goals, we're looking at treating those specific symptoms of that disorder. So for example, if we're able to help this person cope better, if we're able to help them sleep better, decrease their anxiety, treat their PTSD, improve their relationships, so on and so forth, if we address these things, the hope has been that will decrease their ideation and likelihood to engage in suicidal behavior. There are at times where sometimes we will consider hospitalization, of course. Now, certainly there's a time and a place where this is certainly the best course of care. If the person is at imminent risk, absolutely, you know, hospitalization needs to be considered for that person's safety. However, I believe at times as therapists, we might tend to dose our patients at a higher level of care than what's needed, based out of our own fears and anxieties. You know, no one wants to have a poor outcome when it comes to treating a suicidal individual, because that poor outcome is quite significant. And so we kind of really tend to err on the side of caution. However, sometimes that is not at all what the patient needs if they are not at imminent risk, and we're just responding out of our own particular fears and anxieties as therapists. You know, to kind of use an example, if we went to our primary care manager and we were experiencing you know, symptoms of the flu, we're expecting them to treat us appropriately. If the knee-jerk reaction from our primary care was to hospitalize out of fear that this would develop into something greater, we would probably question their rationale for that, right? So, you know, it might seem like a silly comparison, but in a lot of ways, that's similarly to what we're doing with our patients when we're having that knee-jerk reaction. We're responding out of our own fears and anxieties. So on the other end of the spectrum, sometimes we are not treating appropriately by undertreating. Very often we will assess somebody and sort of wait for them to fill in the blanks about their suicidality, with the expectation that if they're coming in for treatment and they're experiencing these things, that they are going to be forthcoming about all the details related to their ideation or their suicidal behaviors. And however, that's not the case very often. For many people, they will not share those details until they are specifically prompted to do so. So I just wanted to take a minute for some reflection, you know, looking at these questions here and thinking about your personal practice and how you treat the suicidal individual. I know that prior to me engaging in CAMS, I had a really limited experience with working with suicidal individuals outside of, you know, just clinically doing what felt was needed at the time when they came in for treatment. But as far as a real education base, that was limited. most folks that I talk with in these or similar trainings say the same thing, that, you know, when I was in my MSW program, we had classes on, you know, everything from A to Z, you know, documentation and how to work with children, how to work with groups, how to incorporate someone's religion or spirituality into practice. But there really wasn't a whole lot of class materials focused on how do you treat the suicidal individual. And so that's something that, you know, we often kind of do within our practice. Once we get into our agencies, we learn by experience. We learn from folks that we work with. Our practice is informed by the different policies and procedures at our agencies. And, you know, we do the best we can, but we can likely identify that there's probably some areas and room for improvement. So for me, this is where CAMS came in. It's a much different approach than, you know, what I had been used to. It's a therapeutic framework which allows for a lot of flexibility to still retain who you are as a clinician. You're not having to completely adjust your practice to a manualized approach, which there's nothing wrong with that. There's a lot of, you know, I use that very many manualized approaches very often, but CAMS is unique in that you can find how it works for you as a clinician. And it offers a lot of flexibility. So this is a real collaborative approach. And, you know, the figure that I showed there where, you know, the red and yellow people are sitting next to each other is not just a depiction for our conversation here today, but it's quite literally how we sit in CAMS. We begin to partner with the patient, and we bring, with their permission, of course, a chair right next to that individual, and we work through this together. In CAMS, you know, suicide is the main focus of treatment, and so we really explore the person's suicidal thoughts and their behaviors, and we investigate alongside them, you know, what's led them to this point. And we look to the patient to be the expert as opposed to us being the expert. All right. So, as I said, CAMS is a framework, and here are some of the CAMS constants. So, CAMS is always collaborative. We consider the client to be a co-author in their treatment plan. We want them to inform their care. We want them to indicate what they believe is driving their suicidality. Within CAMS, we do a very thorough assessment from the beginning, and it's ongoing throughout the duration and course of treatment. We rely on something called the suicide status form. And that's something at the initial session. The assessment structure on the SSF is very thorough. And then we use components of the SSF ongoing throughout the interim session. And we really look at assessment on those 5 constructs there. And we'll talk a little bit more about those in just a minute. I apologize, I'm about to cough, so I'm gonna look away. As I'm sure many of you can relate to trying to deal with this cold weather and all of the ailments that come along with that. So we continue the assessment ongoing throughout the course of treatment. And in the management piece, we really have a strong focus on safety planning. That's something that we start from the very beginning with CAMS, is we create a solid safety plan with the client. And we continue to focus on reviewing and updating that safety plan as it's needed throughout the duration of our treatment. There's also a strong focus on treatment planning from the very beginning. So we're constantly looking at what we consider to be the patient's suicidal drivers. So those are specific treatment goals that we're going to be focused on, and the suicidal drivers are what the patient believes are the two main things contributing to their suicidal thought. So within CAMS, we're constantly working with the patient, we're constantly assessing, we're constantly reviewing safety and identifying, are we really focused on the heart of the problem of what's creating these suicidal thoughts? And during the course of treatment, very often other things develop, right? They will have additional insight, concerns, stressors, and as those things come up, they're certainly acknowledged. However, the difference is if they are not something that is a driver to that individual's suicidality, we kind of respectfully defer them to a later date in treatment. So if they are not part of the problem of suicide, then we table it essentially until we address specifically what's driving the suicidal thoughts and behaviors. So in CAMS, we have 3 distinct phases. So in the initial phase, like I was saying, we start with the SSF, the suicide status form, to get that thorough assessment, safety plan, treatment goals, and then there are all interim sessions, which there's no magic number that we have to follow in terms of the interim sessions. In all of our research, we find that most individuals are resolving CAMS 12 sessions and under. So in those interim sessions, we continue for as long as we need to. Of course, I've had people who've gone shorter than 12 and greater than 12, but we continue the assessment piece, and we also continue treatment planning. And as we find, we gather more information about this person's risk, what's contributing to the risk. We continue to sharpen their suicidal drivers, meaning we continue to focus on getting more specific. So for example, if someone says at session 1, it's my depression that's making me suicidal, that's what they are identifying. And then we look at, well, depression makes up of a lot of things, right? So what about the depression? And we might then drill that down into it's specifically feelings of worthlessness, let's say, and we really focus in as much as we can. And then the outcome or disposition session, when CAMS is resolved, which the resolution criteria is that an individual is continuing to manage their thoughts of suicide independently. So there's no ER visits or hospitalizations, things like that. That the individual is not engaging in any suicidal behaviors. So that includes any kind of rehearsal or preparatory behavior as well, not just attempts. And the individual is marking a suicide risk of less than 3 on the SSF for 3 consecutive sessions. At the 3rd consecutive session is when we make the when the resolution has been met. So at that point, we conduct a review of treatment, and we really want the individual to gain the insight and recognize what has changed for them. Not just I feel better, but why do you feel better? And really begin to kind of ensure that they're making those connections for themselves. And then also looking at kind of a relapse prevention plan of sorts. So if a suicidal crisis develops again in the future, what are you going to do differently? How do you now know that you can address this problem? So, of course, along the way, life happens, right? We all know that there are times when folks come in and, maybe they had a death in the family, or, they had a relationship breakup, or whatever the case might be. There's certainly times where, we have to hit the pause button, right? And address um, if there's something significant that has developed. And in those occasions, we kind of consider it to be a supplemental session. So even though we are unapologetically focused on suicide, we are also understanding that sometimes we need to really be client-centered in that way, and be there for the client when they have these major stressors. Additionally, we are able to use CAMS on more than one occasion. So for example, if someone completed a course of CAMS successfully, and very often when folks finish their course of CAMS, they continue on in treatment and address the things, as I described earlier, that were kind of deferred. So those other focuses of treatment. But if they have another occasion where their risk has increased and they're in suicidal crisis, we can start another course of CAMS. So it doesn't mean that if a suicidal crisis again develops in the future that CAMS was a failure the first time, or that it can't be used again. It most certainly can. And of course, if the individual has been seen on an outpatient basis, the goal is for them to remain outpatient. So we are really, again, collaborative in that approach, that we are not trying to have that knee-jerk reaction that they need to be hospitalized, even if their risk is increasing, as long as they are not in imminent danger. So I just wanted to talk a little bit about some of the foundational aspects of CAMS. So this is a depiction of Shneidman's cubic model of suicide. And so what he's describing here is that when an individual reaches the highest levels of what he calls PRESS, which is essentially stress, or pain, psychological pain, psych ache is another term used for it, and I always struggle with this word, tongue twister, perturbation, which is that anxious energy, that feeling like I just have to act. So when an individual reaches the highest levels of these three domains, that is when the feelings that they are experiencing related to suicide become intolerable, and imminent risk is at the greatest point. When these things in any one construct is to a lesser degree, certainly risk is present, and we need to continue ongoing work and support and treatment, but that imminent risk is decreased. And it's really interesting when you see this play out, because it's something that I've seen time and time again, where just a few weeks ago I was working with a soldier, and he had been really struggling for a number of weeks, and I believe it was like our 5th or 6th CAMS session, and he came in and he filled out his SSF, and he had still really high levels of stress and really high levels of psychological pain, but that agitation, that anxious energy was actually significantly decreased on that day. And he said that he had been feeling really terrible. This was like a Monday or Tuesday. He'd been feeling really terrible all weekend, and feeling very depressed, but he wasn't experiencing the intensity of suicidal thought as he was previously. And it clearly demonstrates when we look at the SSF that yes, you're in a lot of pain, but that feeling that you need to act on that pain was diminished. And so it was for the first time that he really felt differently, and when he was able to connect those dots, for him it was a really significant moment in treatment, because he began to understand, more about what was making his suicidal risk tick. So in addition to Shneidman's theory, our SSF takes from Beck's cognitive theory, hopelessness surrounding self, others, and the future, as well as Baumeister's theory of self-hate. So these 5 constructs of psychological pain, stress, perturbation, hopelessness, and self-hate is something that we get a rating on at each CAMS session. And we track that over time. We want our individuals that we're working with to recognize when their numbers are going up or down. And what's fueling that? What's changing? As we continue that dialogue, it's allowing us to continue to sharpen those suicidal drivers, get them to be more specific and more focused, so we ensure that we are targeting the right goals for treatment. So that's what's really going on in the interim sessions. So we start with this framework of the SSF, which in the beginning is very structured at the initial session. In interim session, that's how the session starts. It starts with checking in on your numbers. And then from there, the session opens up to allow you to be who you are as a clinician, and alongside your patient, drive what you're going to be focusing on, what you're going to be working on. There are a lot of great supplemental forms that CAMS uses to allow the conversation to continue to really help develop this concept of the drivers to that individual suicidality. And it's something that it's really unique in the way that CAMS has created some of these forms to have some variance. So one of the forms that they use is called a therapeutic worksheet, and there are a couple of variations of that. One is kind of more narrative, and the other is more of a visual representation. So this is another thing that I really love about CAMS, because it's really taking into consideration the individual and how do they learn best. So when we're engaging them in treatment, we can adjust how we're focusing treatment. In addition to the direct drivers, we want to focus in on and have a conversation about the indirect drivers. So these are things that aren't directly creating the suicidal crisis, but they're sort of some foundational things that increase someone's risk. So we want to be mindful of those things as well, because while we might not be immediately directly targeting them in treatment, it's something that we want to be mindful of. And we might have the ability to refer that patient out to different ancillary services that can help them address whatever these indirect drivers might be. So for example, someone might identify that an indirect driver is relationship stress. So this relationship stress might be not causing them immediate risk, but it's certainly contributing to some of their depressive symptoms, let's say. So we might refer them to do some couples counseling as an adjunct to what we're also doing in CAMS. So when we're reaching resolution, what does that mean? What does resolution look like? What is our expectation? The expectation is not for this individual to no longer be suicidal ever again in their life, but rather the focus is more for them to be able to manage these crises as they come up. We want them to be independent. We want them to be confident. We want them to have the ability to, I feel like they can handle this and recognize what all the dynamics of what their risk looks like. So what's leading them into crisis. So they can intervene earlier and earlier. We want them to recognize when they're experiencing certain triggers, what are the coping skills that they can use. We hope for them to understand, their different thresholds. So when they're feeling that their ability to manage this independently is diminishing, what their resources are, who can they go to, how can they seek help. This is really a huge, important piece. It's so common for our folks that we work with to be experiencing that perceived burdensomeness, where they feel like whether it's just them or, their symptoms, or even just kind of the general chaos of their life, they feel that that's a burden on their loved ones, their friends, and their family. And so very often they're not engaging with their support system because of that. So when they recognize that they can do more than they realized they could about their suicidal risk, it decreases that feeling of perceived burdensomeness significantly. So of course, in that, we're also talking about hopefully decreasing the frequency or the duration in which they're experiencing thoughts of suicidality, or decreasing the lethality in which they're considering it. So, hopefully in management, the suicidal crisis will become lessened over time. So here are some natural benefits that CAMS has. So as I've shared, since CAMS is a framework versus a model, you really get to be true to who you are as a clinician. But I have on there, you get to be more direct. So what I mean by that is, kind of in my training, being very client-centered, before I was involved with CAMS, if someone came to me who was at risk for suicide, but it was not an imminent risk, of course, we know sometimes folks are less inclined to share information because they might be, ashamed or embarrassed. And so I would kind of take that as, okay, if they're not at imminent risk and that's not the area of focus that they want to have, I would kind of, shy away from it, more so thinking we'll get to it when they're ready. However, when someone is coming in at risk for suicide in the CAMS model, I get to be a little bit more direct. It's less of a passive approach of, all right, we'll get to it when we get to it. It's more like, this is, putting the threat towards your life, and let's address it, and then we can get to the rest of these things later. And when treatment kind of, goes maybe in, whether it's self-sabotaging behavior, if it's going in a direction that's not focused on the suicidal risk, we're unapologetically ready to say, hey, this is something that I can tell is important for you, and I promise we'll get to it. But right now we have to work at ensuring, your life is not in danger. So I also mentioned there that the workload is more evenly divided. So, when we find that the client is sort of deferring to us on a lot of things. For example, I'm sure we can all relate to a time where, we're asking an individual, so how did this come to be? Or what do you know about this? When did you notice it? And as we're asking, these assessment questions, they're tending to go, I don't know, it just happens. And not really working at gaining insight into the process and kind of looking to us to figure it out. You know, at those times, it can be a lot of pressure on us as therapists to try to figure it out. But in CAMS, we can kind of pause and say, all right, well, let's stop and let's really think about this, and kind of put the onus back on the patient for them to really be an active participant in treatment. Again, it's collaborative by nature. So we're demonstrating to them, to the patient from the very beginning, that this is something that we're working on together, that I'm not the expert of your situation in your life, you are, and I have tools that we can use, but you really need to be actively engaged to help us figure this out together. Also, CAMS is really meant to have a high degree of empathy. And of course, we all have empathy for our clients, and this is unique in the sense that with CAMS, we're really working to be empathic to the client's suicidal desire. And I don't mean that to say that we are okay with suicide. You know, we're working to treat people with suicidal risk. But what that means is that we work to understand why, for that particular person, up until this point, it seems like suicide was their best or their only option. We really begin to have empathy for the depths of that person's pain that they've been dealing with. And we begin to offer them a plan for another outcome, because they might not have been able to see that outcome before. Also, more than not, I can't really think of many therapists who have had CAMS training who have not felt their confidence has increased surrounding suicidal risk